So as I was saying, um, these trophozoites, they will feed on the hemoglobin by ingesting small amounts of the red cytoplasm, and now the malaria pigments form as the end product of hemoglobin breakdown. And this is the main reason as to why these patients in malaria, those patients suffering from malaria, they will have anemia, the anemia of microcytic and monocytic anemia. So you see, they will record anemia because of these trophozoites that will be feeding on the hemoglobin. So it accumulates as brown black granules in the trophozoite as it grows and becomes globular in form, and the vacuole membrane enlarges. So that is more of the morphology. So the schizoid, remember, as the growth continues, the nucleus, it will divide into several masses varying from 8 to about 32 merozoites in number. So a mature Plasmodium falciparum will contain 8 to 32 merozoites and malaria pigments as well. So it will occupy about two-thirds of the invaded RBCs. So mature schizoids will rupture from the RBC to release merozoites and the malaria pigments, and also the toxins will be released into the plasma. So the entry of toxins, these toxic metabolites into blood circulation of the hosts is the one that will now cause the fevers and the malarial attack. So the incubation time for P. falciparum, we are saying, is 9 to 14 days. That one you have to remember. So these merozoites, those that are not destroyed by the host immune system, they will invade new red blood cells, and they will develop into trophozoites again and again into schizoids, and again they will cause further cell to be destroyed, and this will keep repeating itself until they are exhausted. So remember that one. So these gametocytes, they are thought to form in response to, one, the developing immunity as evidenced by the raised antibody levels. Then two, they can form due to lack of nutrients. If at all the trophozoites don't have nutrients, so they will not form. It will go to the macrogametes and the microgametes, and that's why I'm saying the gametocytes. So accumulation of metabolites of parasitic debris is another reason. So, and remember, these gametocytes are sickle-shaped, and they are also called the crescents. So gametogony occurs inside the capillaries of the red blood cells and the bone marrow, and also in the spleen. So with the growth of the gametocytes, the red blood cell now is gradually used up, and only its skin remains in the form of a sheath enclosing the parasite. So the size of these mature gametocyte is about 1.5 centimeter longer than the RBC. So that one you should be able to note. So for now, the life cycle to continue, these gametocytes, they need to be ingested by a female Anopheles mosquito again in a blood meal, so that it will again ingest sporozoites. Once it bites you, then again the cycle will now continue, and it will be complete. So in primary infection, the gametocytes appear in the peripheral blood about 10 days after the appearance of a sexual parasite in thick smears. So 21 days after inoculation of the sporozoites is now when we'll be able to identify. And these crescents, the gametocytes, they are taken up by the insects. They persist in the peripheral blood for a longer period, 30 to 60 days or even longer. If not taken by a mosquito, remember, they will die. So malaria will now be severe, and once you do your RDTs and thick and thin smears, you will be able to get malaria parasites there. So we dive through the clinical features of malaria. We are saying that the main clinical manifestation In a typical case, the series of febrile paroxysm followed by anemia and then the splenic enlargement. So this paroxysm, as earlier mentioned, we are saying that it starts generally in the early afternoons, but it may start at any time. So the time is not specific. So each paroxysm shows a succession of the three stages. We have the sweating stage, the cold stage, and the heat stage. So the cold stage is the one that will start about 20 minutes or an hour. So the patient will present without headache, but the patient will be feeling cold, and the temperature is usually rising. So once you take the vitals, you will realize that the temperature is the one that is rising. So and this one is caused due to now the rupture, from the host red blood cells, and they will be now escaping into blood. So that one is the cold stage. Then you have the hot stage. So it will last between 1 to 4 hours, and the temperature rises to maximum as it starts invading newer cells. So that is like that. And then there is a severe headache and a backache is there, the joint pains, and in some cases severe diarrhea and severe vomiting also. So those are the symptoms that will be recorded. So remember that. So the sweating stage is another paroxysm. So we are saying that it will last for about 3 hours. And remember, this person will perspire, and the temperature will now fall, and the headache will be relieved, a bit relieved, and other pain will also be relieved. So what you need to know is that the duration of the febrile cycle, the paroxysm now will last for about 10 hours. So the periodicity of the attack, it will vary depending on the species that are infecting. We are saying that for vivax and ovale is 48 hours, for malaria 72 hours. We are saying that for falciparum it may recur in alternate days or continuous. So we say that another one is anemia. And in developing countries where malaria is common, we are saying that anemia is a common feature of pregnancy, and malnutrition and helminthiasis are the commonest cause of anemia. So in such situations, we are saying that malaria will compound the problem. So malaria in pregnancy will likely cause that one, which we are saying anemia. So anemia may be even the presenting feature of malaria. Therefore, all cases presenting with anemia should be done the blood slide for malaria parasites. And now anemia is more common and severe between 16 to 29 weeks of gestation. So that one, the second and the third trimester will record malaria attacks. So once the patient comes to your clinic and a patient has malaria and is pregnant, or a patient presents with anemia and is pregnant, it is good you do a blood slide for MPS so that you can be able to detect, and I recommend that you do a thin and thick smears because those ones are sure. So remember, it can develop suddenly in cases of severe malaria with high grades of parasitemia. So after a few paroxysms, anemia of the microcytic or nomocytic hypochronic types will develop, and it will develop one as a result of direct RBC lysis as a result of the life cycle. Then we are also saying that the splenic removal of both the infected and uninfected RBCs, which they're coated with the immune complexes. And another reason we are saying that the autoimmune lysis are coated infected and uninfected red blood cells. Then you have the decreased cooperation of ions into hemoglobin, And this is one of the reasons why we say that these pregnant women should be on medication, that is the folic acid and the ferrous, so that they can be able to have enough hemoglobin or any other iron supplements. So we are saying that another reason could be increased fragility of the RBCs. Then we also have the decreased RBC production from the bone marrow due to the suppression of the bone marrow. So remember, malaria attacks following treatment with ferrous have shown that there is increase in the severity, because ferrous, remember, is essential for the growth of the Plasmodium falciparum. So that one you should be able to note. Another symptom, we said that we have splenomegaly, but this one mostly is recorded in these kids, and where we are saying that where the spleen is palpable. So splenic enlargement is one of the most important physical signs in malaria, and in first cases the enlargement is so slight, so it will escape detection by palpation. But usually by second week it will definitely enlarge and it will become palpable. Now the spleen enlarges with each attack of malaria because it has to clear, remember, the damaged red blood cells and produce new antibodies. So that's why the spleen may enlarge. We are saying that with the age of 10 years, splenic enlargement is rare in haloendemic areas. But below that age, then splenic enlargement will be palpable. So when a child is in haloendemic areas, when he gets older, he will develop partial effective immunity, and the spleen becomes smaller and probably will be no longer palpable. So in a few cases, however, the spleen continues to increase in size. So this is thought to be an abnormal immunological reaction to malaria, and the condition is the one that we are calling tropical splenomegaly syndrome, the TSS. Now the syndrome will occur only in the malaria endemic areas, and mainly it will occur in the young adults. So that one you must be able to note. Okay, so the features of that TSS, they're saying you have hypersplenism. This one will result into thrombocytopenia and lowered immunity, and also increased bacterial infection. Then we also have another feature, attacks of hemolysis, resulting in anemia and hemolytic jaundice. So you may also find out that jaundice could be a feature of malaria. So you should be able to remember that. And remember, these attacks, they are common in pregnancy, and that's why we are dissecting this topic. And it could be fatal in this pregnancy. So just be keen while handling these cases. So there are raised immunoglobulin M levels with increased antimalarial antibodies. The condition responds to prolonged treatment and antimalarials. So we have also relapse in malaria, and we are saying that is the new clinical manifestation of parasitemia, and one may result from persistence of blood infection in which surviving population of the erythrocytic form are increased. This recurrence is the feature of P. falciparum infection and may occur up to 1 year. So it may occur up to 1 year. Then you have the persistence of the exoerythrocytic forms in the liver, in which erythrocytic schizogomy will commence from. So, and that is a feature of P. vivax. So we have classification of malaria. Now the clinical classification of malaria. and here is where you want to base on, because this is the area that will now help you. This is the area that will help you. So malaria can be classified as either 1, uncomplicated, 2, severe malaria. So complicated malaria is severe malaria. So we dive through the uncomplicated malaria. So it's characterized by 1, fever in the presence of peripheral parasitemia. So if you have fever in the presence of malaria, then that one is uncomplicated malaria. Okay, so fever could be there, but now once you do a BS for MPS, you will be able to notice that malaria is present. So once malaria is present and fever is present, we term that one as uncomplicated malaria. And so stay with us, because you will be able to know how to manage and to treat this uncomplicated malaria. So also remember, other features will include chills. We have profuse sweating, muscle pain, joint pain is another one. Then abdominal pain, you have diarrhea, nausea, vomiting. Those are some of the signs. Irritability, of course, and lack of appetite or refusal to feed, that normally are called anorexia. So remember, these features may accompany each other, or they may occur singly. So you must be able to run a malaria test for you to be sure about what you are doing. Okay. Okay, so that is all you need to know about uncomplicated malaria in the clinical presentation. And we also have severe malaria, or the complicated malaria. Now, so this is the life-threatening manifestation of malaria, and is defined as the detection of Plasmodium falciparum in peripheral blood in the presence of any of these clinical or lab features as listed below. I hope you can be able to see. The first one is prostration, and this we are saying is the inability or difficulty to sit upright, and also difficult to stand or difficult to walk without support. And normally in a child able to do so, or the inability to drink in children who are too young to sit. So that one, we'll term that one as severe malaria. So alteration in the level of consciousness, this will range from drowsy, once you start feeling drowsiness, then to deep coma. That is how severe it can be and how fatal it can be. So must be able to manage them correctly. Then you have cerebral malaria. So this cerebral malaria is an arousable coma not attributed to any other cause in patients with P. falciparum. So if someone has an arousable coma and that does not have any other condition, then we are saying that this could be severe malaria, especially with confirmed tests showing that Plasmodium falciparum is present. So this is because the parasite will clog at the artery and they will cause embolism, hence lack of support. So what you need to do as a health practitioner, this will need an intensive care, and the interventions will include the ABC of coma, the prompt institution of antimalarials. Remember, you must act real quick. Then the management of hyperpyrexia, because remember the temperature on the rising scale. Then you're also saying that management of other complications. Then remember to treat also the associated infections, because sometimes it could be associated with other infections. So just be sure to manage other associated infections if there. So respiratory distress is another one. Then you have multiple generalized convulsions. These are now two episodes or more within the 24 hours. So shock is another one, and this one is now the circulatory collapse due to septicemia. So remember that one as well. Then we have pulmonary edema. This one is very common in pregnancy. This one is very common. So you must take note of it. It is very common. Okay, so let me see. So I have told you that pulmonary edema is very common. So in pregnancy especially, so acute pulmonary edema is a more common complication of malaria in pregnancy compared to the non-pregnant population. So it may be the presenting feature or may develop suddenly after several days, especially in the second and the third trimesters. So it can develop suddenly in immediate postpartum period due to one or to transfusion of placental blood with the high proportion of parasitized red blood cells. Then it could also be due to the sudden increase in peripheral vascular resistance after delivery. So those are the reasons. So it could also be aggravated by pre-existing anemia and the hemodynamic changes of pregnancy. So it carries a very high mortality. Carries a very high mortality in this population. Then also remember the abnormal bleeding could, if present, then we say it is severe anemia. Abnormal bleeding, the one that we are calling the DIC. Okay. So I know you may want to know how this DIC or abnormal bleeding will occur in this pregnant population or in severe malaria. So the abnormal bleeding, let me at least discuss that one. This DIC is the one we are calling disseminated intravascular coagulation. Now, in malaria occurs as a result of the complex interaction between the parasite as the plasmodium and the host's immune and the coagulation system. So the coagulation system in man and the host's immune system, the same man. So the interaction now between the complex malaria and the immune system. So is the one you are saying. Now this phenomenon, remember, is most commonly seen in severe forms of malaria. So severe falciparum can lead to life-threatening complications. So remember the pathophysiology of DIC and abnormal bleeding in malaria. One, we are saying that you have the endothelial damage and activation of the coagulation cascade. So this is to mean that in malaria, infected red blood cells, they will adhere to the endothelial cells lining the blood vessels. So this process is the one that we are calling the cytoadherence. Okay. So this adhesion, along with the parasite toxin, they will damage the endothelium and they will expose the subendothelial cells, activating the coagulation cascade. So that's what we are saying. Then another thing could be due to the overactivation of the coagulation system. And remember the release of the pro-inflammatory cytokines, e.g. those ones, the TNF alpha, those ones. I know you know them. So during malaria infections, it will trigger excessive activation of the clotting factors, and platelets will become consumed in the formation of uh, um, the microthrombi. So those thin clots in small blood vessels throughout the body. Then another thing will be the consumption of the coagulation factors and the platelets. So remember, the continuous formation of clots, it will deplete the clotting factors, e.g. the clotting factor 5, you have the prothrombin, the fibrinogen, and the platelets, and this will lead to consumptive coagulopathy. So remember, as these resources are depleted, your body now will be unable to effectively form clots. Then it will lead to the abnormal bleeding. So that one you need to know. You need to really know. Then another thing, we talked of jaundice. So remember, jaundice is there. We are also saying we could, in severe malaria, present with hemoglobinuria, what we are calling black water fever. Then the acute renal failure will present as oliguria or lanuria. Then severe anemia, that is HB of less than 5. That one is true. Then the hematocrit count of less than 15%. So that one is hypoglycemia is another one. So that one is blood glucose below normal, that is 2.2. So in pregnancy, is due to one, the parasite will take up the glucose. Then two, will have the poor intake of sugar, especially in starvation. Then three, we have the use of quinine, and that's why quinine has been questioned. And the management by the use of quinine, you really have to be keen so that you don't fall into these traps. So when you are using quinine, make sure at least you do dextrose, so that you could be able to counteract this. So increased response of pancreatic islets to secretory stimuli like quinine, in this case, will lead to hyperinsulinemia and thus hypoglycemia. So remember, hypoglycemia in this specific group of patients may remain asymptomatic and may not be easily detected, because the presentation at times will mimic the malaria presentation, and in some cases it could present like cerebral malaria and could easily be confused. Therefore, it is wise in all pregnant women with falciparum malaria, particularly those receiving the quinine, the blood sugar should be monitored every 4 to 6 hours, and that one should be keen. Now, the effects of malaria on the fetus. What are the effects of malaria on the fetus? One, we are talking about high-grade fever. Two, we can have placental insufficiency. Hypoglycemia remains to stand out, and then anemia is another thing. So there is a very interesting fact here, that these primigindavidae may develop more clinical symptoms of malaria. However, these women with higher immunity, they may not demonstrate those symptoms. So we are saying that that will lead to more placental burden, and more fetal complications will occur. And we are saying that one could be the spontaneous abortion. We could have a premature birth. A stillbirth could as well occur. Then low birth weight has been recorded in most cases. Then congenital malaria as another one. Perinatal and neonatal mortality could also occur. And we are saying that those are some of the things that we are trying to handle as at now, so that we don't have this neonatal mortality or the perinatal ones. So we have the pernicious malaria. So is a term referring to a series of phenomena occurring during the course of infection of P. falciparum, which is not well treated, and it threatens life of individual within 1 to 3 days. So pathogenesis, we are saying that the serious complications that may develop in pernicious malaria are as a result of One, the capillary blockage will consequently decrease circulatory blood volume. Two, in the long being thought that the blockage of the capillary blood vessels of the internal organs will arise from agglutination of parasitized erythrocytes peculiar. So this has been attributed to certain biological features of P. falciparum, such as one, stickiness of the infected erythrocytes. Two, the recession of the sexual parasite from the peripheral circulation to the blood vessels in the internal organ later stage of the schizogony. Then also segmenting form of the parasites, unable to alter their shape. Then the growing trophozoites becomes adherent to one another in the wall of the vessel, leading to blockage. Then peripheral circulation will show a heavy parasitemia, as various ring forms will be seen. Now, another one, the stasis, resulting from the vasoconstriction itself due to sympathetic hyperactivity, plays an important role in the capillary blockage. So stasis will mean loss of fluid from the vessel due to increased permeability of the endothelial cells, allowing heavy molecules and water to pass. So that is it. So clinical types of pernicious malaria have cerebral malaria, and this one we said manifested by hyperpyrexia, coma, and sometimes paralysis. So it is the commonest cause of death in P. falciparum, and is due to parasitized red blood cells and fibrin blocking capillaries and venules in the brain. So there may be hemorrhage from those small blood vessels. So algid malaria is another one that you need to know. This one is characterized by all those symptoms of shock. So malaria with symptoms of shock, that one is what we are calling algid malaria, and characterized by cold, clammy skin with vascular collapse leading to peripheral circulatory failure. Along with this, there may be vomiting, watery diarrhea, or passage of blood in feces. So septicemic malaria is another one. Black water fever is another one. So in black water fever, what you need to know, the etiology of black water fever, the exact cause is unknown, but remember it's associated with P. falciparum infection, and is now commonly found in non-immune and non-indigenous persons who have settled in the malaria endemic zone for about 1 year, and they have inadequate chemoprophylaxis or antimalarial treatment to relieve that malaria. So it is thought, following repeated attacks of the falciparum, a person forms an autoimmune factor which is in rapid hemolytic reaction. So if the person becomes infected with the same species, that causes the hypersensitivity. So the precipitating factors to black water fever, we have administering of antimalarial drugs, exposure to extreme temperatures, and then the abnormal physical activity and fatigue. We have trauma. So pregnancy and delivery is one of it, and that's what we are discussing here. So exposure to X-ray and alcohol abuse would be really dangerous. So the urinary changes in black water fever, what you will be able to notice, the color of urine will vary from red to brown due to too much albumin. That one you must be able to note. Then you have the urine will be strongly acidic. So when allowed to settle, there is a heavy brown deposit in the bottle. So this one is for those lab techs, my friends, the lab technicians. This is for you. So albumin is excreted in large amounts is another change that has been reported, and bile may occasionally be present, and on microscopy hemoglobin cast and hematine crystal are found, but there will be no RBC. So complications, it could go to as worse as the renal failure due to acute lobular damage. Then we could have also acute hepatic failure, circulatory collapse is another one. Then development of severe anemia. So let's now see how will you be able to diagnose these this malaria now, the parasitological diagnosis of malaria. So we are saying that the commonly used confirmatory test to detect the presence of malaria parasites are: one, the microscopic, then the rapid diagnostic tests currently available, RDTs, and we have the histidine-rich protein 2, that is the HRPP2. Then you have the asexual stage and young gametocytes of P. falciparum. So the molecular one, the serology, the immunology, and the clinical. So that clinical is the clinical suspicion. So you can diagnose malaria clinically if you take a very good history and of the patient, and you perform a very good physical exam. You will be able to come up with diagnosis of malaria. So on the microscopy now is the standard method for parasitological diagnosis of malaria. This because it will include the thick and the thin film preparations. Remember, the thick preparations are for identification of the parasite, and now the thin preparations are for the identification of the species of the parasite. So the RDTs, diagnosis of the RDTs, they are not standard. And now these RDTs, remember, they are immunochromatographic tests based on the detection of specific parasitic antigens. And if you are using an RDT, then remember the blood slide can still show positive and thereafter meant for somebody who has never been treated for malaria. So the use of RDT is, however, not recommended following the previous confirmed cases. So remember, this one could easily misdiagnose, and so it is not recommended. But where there are no resources, you'll have no other ways but to perform using the resources available. So most tests remain positive for between 2 to 3 weeks following effective anti-malarial treatment and clearance of parasites. So RDTs cannot be used to determine the parasite density, whether we have hyperparasitemia or not. So other parasitic detection methods, we have the detection of the antibodies to malaria parasite. We have the detection of the parasite DNA by the use of the polymerase chain reaction, that is the PCR. And remember, these two methods are not used for routine, mainly in Kenya. And the first is non-specific, while the second is highly sensitive and very useful for detecting mixed infection. So when you are using the PCR, you will be able to detect mixed infections. And the parasites are not detected at times in peripheral blood smear because, one, we could have the sequestration of the deep vascular bed. Then we could also have partially treated patients. Remember, the patients who present with malaria, if they have taken or pre-med, have taken antimalarials, then you won't be able to diagnose malaria or to show the parasites in the RDTs. So remember that. Then the prophylactic antimalarials, then the inexperienced technicians, then poor quality staining. So don't fall under the inexperienced technicians. Just be competent with your work. Now, the management of malaria in pregnancy. So management of malaria in pregnancy, it will involve the following three aspects, and all of them are equally important. So they should be monitored. One, you should consider the treatment of malaria. Then two, the management of complications, and then 3, management of labor, because remember we are dealing with malaria in pregnancy. So about treatment of malaria, so treatment should be 1, energetic. This is to mean that you should not waste any time. Then it is better to admit all cases of P. falciparum, because they could turn to be severe. So once you are assessing the severe, you cannot assess severity with patients when they are not in the hospital. So it is good you admit all the cases. Okay, my slide is here. Yes, so number 2, you are saying that the treatment of malaria should be anticipatory. This is to mean that you look for any complications by the regular monitoring. Then you should also monitor the fetal and the maternal vital parameters after every 2 hours if it's possible. Then remember the HB or the hemoglobin and the parasite count should be done at least 12 hourly, at least after 12 hours. So remember the treatment should also be careful. This is to mean that choose the drug according to the severity, because some drugs are contraindicated in pregnancy. So what you do, you avoid them. Then also avoid overload, because they may lead to dehydration. Then maintain an adequate intake of calories, and also avoid underdose or overdose. So that is it about treatment of malaria. That's how it should be. So another thing we have said that also we have an aspect of the management of complications. So when managing complications, patients presenting with signs and symptoms of uncomplicated malaria should be tested for malaria, and those who test positive should be treated for malaria. Okay, thank you. So remember, we are saying that the first line treatment for all age groups, let's dissect through it. Now, due to the increasing resistance of P. falciparum, the WHO recommends the combinations. So these ACTs, the artemisinin-based therapies, the artemisinin-based combinations, as suggested and recommended by the WHO, we have the artesunate and mefloquine. Then we have the artesunate amodiaquine. We have the artesunate and SP. That is sulfadoxine pyrimethamine. Then we have the hydroartemisinin and piperaquine. Then we have artemether and lumefantrine. So in Ghana, the recommended first-line treatment for uncomplicated malaria in pregnancy is artesunate plus amodiaquine. So artesunate and amodiaquine are the one now being recommended in most countries of the Western Africa. And remember, this one replaced chloroquine, which was initially being used, and it was about in 2005 due to the decreasing efficacy of the chloroquine, and the falciparum now had undergone the mutations, and it was now resisting the chloroquine, so they had to do artesunate and amodiaquine. So while the recommended first-line treatment of uncomplicated malaria in pregnancy in Kenya and Uganda and these Eastern African countries, as at now, is the artemether lumefantrine. That is because it's also available in child-friendly tablets. Then remember, the available one, we have the 20 milligrams of artemether and the 100 milligrams of lumefantrine. We also have the 40 milligrams of artemether and 240 milligrams of lumefantrine. Then we have the DS tabs, the tablets DS, the 80 milligrams of artemether, and 480 milligrams of lumefantrine. So remember, the dosage will depend on which one are you using. If you are going with the AL, then you should be able to know. If you are doing the 140 mg, then this is the dosage. So we go with kgs. So if for those who are 5 to 14 kgs, they'll take 1 tablet. Then 15 to 24 kgs are going to take 2 tablets, and 25 to 35 kgs 3 tablets. Then above 35 kgs adults, they are going to take 4 tablets. And in pregnancy, mostly you are going to deal with 35 kgs and above, so they are going to take 4 tablets at 0 hours, then at 8 hours, at 24 hours, and so this 24 hours from the first dose. Okay, so if they are taking 4 tablets at 0 hours, then the third dose are going to take 24 hours after the first dose. So this is the one that is narrowed down. Now for children below 5 kgs who are confirmed, the current recommendation is a half tablet of the L given according to the schedule. And I hope you have heard that. So counseling and follow-up. So demonstrate the preparation and administration of the drug to care given of patients, to care given to children. So if vomiting occurs within 30 minutes after the drug administration, remember the dose is going to be repeated. So that one you must note. Then the supportive treatment. The supportive treatment, remember we have the fever management. So we have been using paracetamol in management of fever because it's the recommended antipyretic. So that one is commonly used. You can use that one as well. So remember that. Then other methods, we have exposure. Just expose that patient. If they are covered, and cover them, because you are trying to manage the fever. So we have tepid sponging. This is the use of warm water. So don't use cold water because of the risk of chills. So and shivering could come in. So remember, we are managing fever. So just do tepid sponging with lukewarm water. Then the fanning is also. Then you should also encourage adequate fluid intake and food intake, and should be in smaller quantities but at frequent intervals. So that is it. Then treatment failure. If at all we have treatment failure, then it's defined as failure to achieve the desired therapeutic response after the initiation of the therapy. So it should be if it's suspected, then remember the patient will deteriorate clinically, and the symptoms may persist for 4 days, 3 to 4 days after the initiation of the drug. So when we have treatment failure, that is now when we come to the second line treatment. Now we are doing this because we have this drug called the artemether piperaquine, commonly called the docotexin or the pialaxin. So this one comes in once we have the ACTs that were first line, if they fail. So we come to this. So this is currently available as the fixed dose combination in adults. So it contains 40 milligram of dihydroartemether and 320 milligram of piperaquine, and this is administered once daily for 3 days. So you are taking 3 tabs once daily up to 3 days, and you will be done. So only confirmed cases of the treatment failure should be treated with the second line. So that one you should not. Now, management for severe malaria. So thank you. The management of severe malaria. We are saying that the recommended treatment for severe malaria is the parenteral artesunate. The preferred route, remember, it's the IV, the intravenous. However, intramuscular can be used where the IV line or the IV route is not visible, but kindly stick to that intravenous, because that one is the recommended. Now the dosing, if you are doing the IM, then you are doing 3.2 mg per kg start, then as the loading dose, then the maintenance dose you are doing 1.6 mg per kg until the patient is able to tolerate oral medication. Now, so once this oral medication you start to give, then you are giving artemether-lumefantrine for a complete course. That is it. And so we are also doing intravenous artesunate. First of all, you have to dissolve the artesunate powder with 5% sodium bicarbonate solution, which is provided. Then also dilute the resultant solution with 5 ml of normal saline, which are also provided, or sometimes you do 5% dextrose. Then administer 2.4 mg per kg by slow IV injection. Then at 12 hours also redo the same. Then at 24 hours also administer another dose of artesunate until the patient is able now to tolerate the oral medication. Remember, the first 3 doses are mandatory. The patient should be able to complete those ones, and you can continue for up to 5 days if the patient cannot tolerate oral medication. But once the 3 doses are complete, and the patient is able to tolerate now oral medication, you are going to give oral medication, and that is the AL, a complete course of artemether-lumefantrine. So we are saying this because remember, when you are giving these injections, they will only clear up to 90 to 99% of the parasites. So you must also give a complete course of oral dose so that to eradicate the parasite even more. Okay, so that is it for artesunate. Then we go, another drug is artemether, and it is dispensed as a clear oily solution of different concentrations. So it must be given IM. So this one is strictly intramuscular. And remember, you are doing a loading dose of 3.2 milligrams per kilogram. Then that is that's loading dose. Then the maintenance dose, still doing IM 1.6 mg per kg. So remember, you are doing that daily until the patient is able to tolerate oral medication. Thereafter, a complete course of artemether-lumefantrine should be given. Now, if you are using quinine sulfate, then you are only giving it as an intravenous infusion and not as an IV injection. Never give us an IV injection. So you are doing a loading dose, and remember, it can be omitted if the patient has received quinine in the last 24 hours, or that same patient has received mefloquine in the past 7 days. So you are not doing the loading dose. Remember, it's not contraindicated in severe anemia, so you can easily give. And in renal insufficiency, you should remember to maintain the same dose, but in hepatic insufficiency, the dose of quinine is reduced by 25%. So for even infusion, you are typically doing 5% or 10% dextrose. You are using that. Then at least 1 ml, 1 milligram of 1 milliliter of the fluid, and should have 1 milligram of quinine to be given. So that is it. Then remember, you should not infuse this quinine at a rate of more than 5 mg per kg per hour. Then remember to use D5 normal saline for infusion with 1 ml of fluid for each, then 1 mg of quinine. So that one is like that. You should be able to know. So we don't recommend for intramuscular quinine. So hypoglycemia is a potential side effect of quinine. So administration, particularly in pregnancy, should therefore be administered in a glucose-containing infusion, e.g. 5% dextrose. Then there are these drugs that are contraindicated in pregnancy. So let's dive through. One is the tetracycline, because it easily causes the abnormalities of the skeletal and the muscular growth. And remember, the tooth development, and it will also go and affect the eye, that is the lens and the cornea of the eye. So that one is not indicated in pregnancy. So another one is doxycycline, because of its risk of cosmetic staining of the primary teeth in this newborn. Then it's excreted in breast milk. So primaquine is another one. It's harmful to newborns who are relatively deficient of the glucose 6-phosphate dehydrogenase, that is the G6 PD. Remember that one. Don't give those drugs. So how are we going to manage these complications? If a patient comes to you, then let's say the patient has renal failure, or has algid malaria or septicemic shock, then has PFAL sputum at the same time. How are you going to manage? So we start off with acute pulmonary edema. So in the management of acute pulmonary edema, you are doing careful fluid management. Then you are encouraging the patient to have a back rest. Then remember to use ventilation where needed, then oxygen as well. Then you should not forget to give these diuretics, because diuretics will help in acute edema, and they are the drugs that we normally give. So other complication could be hypoglycemia. Hypoglycemia, I've said, you do D25 or D50, that is 50 to 100 ml as an IV infusion, followed by dextrose 10% as continuous infusion. Then if there is fluid overload, we are saying that you are going to inject glucagon 1 milligram, then you are doing that intramuscularly. So blood sugar should be monitored thereafter every 4 or 6 hours for recurrent hypoglycemia. Then remember, for anemia, what you are going to do for those packed cells, they should be transfused, because if the HB is below 5, then that one is could be fatal, so they should be transfused. Then in case of renal failure, remember this could be prerenal due to an unrecognized dehydration, dehydrating, or renal due to hyperacemia. So the treatment will involve careful fluid management and diuretics as well. And in this case, you could do dialysis if need be. Another complication could be septicemic shock, or the one we are calling algid malaria. So this could be secondary to bacterial infections like UTI, the pneumonia, and these are the more common in pregnancy, and they are associated with malaria. So treatment involves administration of the third generation cephalosporins. That will be ceftriaxone or cefotaxime. Then you're also doing fluid replacement. Then monitoring of vital parameters is really important, and we should also monitor the intake and the output. So that is it. So during labor, remember careful monitoring of maternal and fetal parameters, because fetal distress is common and remain unrecognized. So that is very important, and all efforts should be made to bring temperature under control by cold sponging and the use of antipyretics like paracetamol. So now malaria control in pregnancy. We are saying that antenatal care is very important, and health education as well. So intermittent preventive treatment is also very important. Use of insecticide treated nets is very important. Clearing of bushes is very important. Then case management of malaria disease is the key one that we are looking at. So the intermittent presumptive treatment, we are saying based on assumption that every pregnant woman in a malaria endemic area is infected with malaria, recommend that every pregnant woman receive at least 2 treatment doses of effective antimalarial drugs, and that is the sulfadoxine pyrimethamine, and that is currently considered the most effective drug for IPT. So remember that one. To finish off, vaccine, the malaria vaccine is in development still, so there is no licensed vaccine against malaria that exists. So the parasite has evolved a series of strategies that allow it to confuse, hide, and misdirect the human immune system. So the parasite changes through several life stages, even while in human hosts, presenting a different subset of molecules for the immune system to combat at each stage. So remember, there is no vaccine for malaria currently, but you can do the prophylaxis. You can use the tetracycline, the mefloquine when traveling. So remember that. And also, what is very important, you can use these mosquito repellents and clearing bushes, and that's very important so that we can be able to keep our pregnant mothers safe. So thank you so much for your time. That was the presentation. In case of any question, just channel it. We shall be able to answer every question, and you are welcome. Thank you so much. Enjoy your evening.